Welcome to this Step 3 review on pediatric stomach and intestinal problems, brought to you by Roadmap to Residency. We are not going to reteach pediatric gastroenterology from the ground up. Instead, we will show you exactly how the test writers build these question stems and how to attack them. We will cover sudden infectious diarrhea and dehydration, constipation and stool soiling, belly pain, including appendicitis and telescoping bowel, and vomiting and reflux. Every one of these shows up on Step 3 wearing the same few disguises, and once you learn the disguises, the questions become fast, easy points. Keep your question bank open beside this video. Let us get started. Here is our plan. First, we will break down the 4 pediatric stems that Step 3 reuses over and over: infectious diarrhea with dehydration, constipation with stool soiling, belly pain that could be appendicitis or telescoping bowel, and vomiting and reflux. Second, for each one, we will pull out the trigger words that let you commit to an answer before you finish reading the stem. Third, we will work through 4 practice questions together, and I will explain why every choice is right or wrong, because the wrong choices are where the test writers teach you the most. This video assumes you already have baseline knowledge. We are here to sharpen how you take the test. Our first strategy is to anchor on 2 things in every stem: the age and the hydration status. Start with age, because it is the most powerful clue on the page. Telescoping bowel lives between 6 months and 3 years. Appendicitis climbs sharply once the child reaches school age. Reflux, that is just spitting up, peaks around 4 months and fades by the first birthday. Constipation with soiling only appears once a child is old enough to have been toilet trained. So read the age first and watch half your answer choices die on the spot. Now the second anchor, hydration. Whenever a child is losing fluid, the test writer hands you a hydration exam. If the child is alert with moist lips and normal capillary refill, you give fluids by mouth. Here is what trips people up. Even with sunken eyes, no tears, and slow capillary refill, you still give fluids by mouth. You only go to the vein when the child is lethargic, cool and mottled, or in shock, or when fluids by mouth have already failed. Find that hydration sentence before you look at the choices, because that sentence, not the diarrhea, picks your answer. Strategy 2 is to separate the sick belly from the well belly, and this single sorting step decides most of these questions. First, hunt for the surgical belly. Certain phrases mean stop reading and act. Green vomiting in a newborn is a twisted bowel until proven otherwise, and the answer is an urgent upper gut contrast study, not observation. Guarding, rebound tenderness, and pain that started near the navel and moved to the right lower belly point at appendicitis. Sudden crying spells where the child draws the legs up, a sausage-shaped mass, and current jelly stool point at telescoping bowel. When those phrases appear, your answer is imaging or the operating room, never reassurance and never a laxative. Now, if none of those red flags appear, flip your mindset, because Step 3 rewards the calm outpatient answer. The thriving 4-month-old who spits up but is growing along his curve needs reassurance and thickened feeds, not medication. The constipated child with a soft belly needs stool softeners and a toilet routine, not a scan. Be suspicious of any choice that starts acid-suppressing medication, orders advanced imaging, or admits a well-appearing child who is feeding, drinking, and growing normally. Strategy 3 is to learn the trigger words, because a single phrase usually decides the answer. Here are the 3 that earn the most points. First, the dehydration trigger. Watch for alert, drinking eagerly, and tears present. That combination sends you to fluids by mouth, even when the stem piles on scary numbers about fluid loss. The trap is an answer offering the vein for a child who is still awake and thirsty. Save the vein for lethargy, shock, or failed feeding by mouth. Second, the constipation trigger. Watch for soiling in a child who is already toilet trained. That is not a behavior problem, and it is not diarrhea. It is retained stool leaking around a hard mass. Your answer is to clear the stool out first, then maintain with softeners and a daily toilet routine. The trap is any choice suggesting counseling or punishment. Third, the reflux trigger. Watch for growing along his curve or gaining weight appropriately. A spitting up infant who is growing well has harmless reflux, and the answer is reassurance. Now watch for the opposite words: poor weight gain, blood, green vomit, or forceful vomiting after every feed. Those words turn that same stem into a real disease that demands a workup. Let us work through our first practice question. An 18-month-old boy comes to the clinic with watery diarrhea and vomiting for 2 days after attending daycare. He has had 6 loose stools today. On exam, he is alert and irritable but consolable. He drinks eagerly when you offer a cup. His lips are slightly dry. He makes tears when he cries, and his capillary refill is 2 seconds. He has lost about 6% of his body weight. The question asks for the most appropriate next step. Before you look at the choices, find the hydration sentence. Notice the words alert, drinks eagerly, and tears with crying. Notice also that the STEM is trying hard to scare you with 6 loose stools and 6% weight loss. Read the 4 options, commit, and we will reason through everyone together next. Let us break this down. Step 1. Spot the pattern. Watery diarrhea and vomiting in a toddler 2 days after daycare is viral inflammation of the stomach and intestines, the most common cause by far. But the real question is not what caused it. It is how dehydrated is this child. Alert, drinking eagerly, tears present, and capillary refill of 2 seconds is textbook mild to moderate dehydration. This child is not in shock. Step 2. Apply the rule. Mild to moderate dehydration in a child able to drink is treated with fluids by mouth using an oral rehydration solution in small, frequent volumes. And here is the detail that catches people. The fact that he is vomiting is not a reason to skip fluids by mouth. You give small sips more often. Step 3. Eliminate the wrong answers. Choice B, a line and fluids through the vein, is the classic overkill trap. The vein is reserved for the lethargic child, the child in shock or failed feeding by mouth. Choice C, stool culture and antibiotics, is wrong because this is viral. Antibiotics do not help, and in certain bacterial infections, they raise the risk of a dangerous kidney complication. Choice D, loperamide, is dangerous. Medicines that slow the gut in young children risk poisonous swelling of the colon. The correct answer is choice A, fluids by mouth with an oral rehydration solution. The weight loss number and stool count were noise. The hydration exam was the signal. Here is our second practice question, and it hides its answer behind an emotional detail. A 6-year-old girl comes in because she has been soiling her underwear almost daily for 3 months. Her mother is frustrated and insists she is doing it on purpose. On further history, the girl passes a very large, hard stool about twice a week, and she says it hurts. She was toilet trained at age 3. She is growing normally. Her belly is soft, but you feel a firm mass in the left lower quadrant, and her spine and neurologic exam are both normal. The question asks for the most appropriate next step. Notice what the STEM gave you: a toilet-trained child, painful hard stools, and a firm mass on the left. And notice it took away every red flag by telling you the spine and neurologic exam are normal, and she is growing well. The mother's theory that this is intentional is a distractor, not data. Choose your answer, and we will work through all 4 choices next. Let us work through this answer. First, read the soiling correctly. Soiling in a previously toilet-trained child is almost never willful and almost never diarrhea. It is liquid stool leaking around a large, hard, retained mass, which is exactly why it happens without the child noticing. The STEM confirms this twice: large, hard, painful stools only twice a week, and a firm mass in the left lower quadrant. And it carefully closes every other door by telling you the spine is normal, the neurologic exam is normal, and she is growing normally. Now, why does clearing the stool win? Because you cannot fix the leaking until you remove the dam. You clear the retained stool first, then prevent it from coming back with maintenance softeners and a daily toilet routine. That 2-step approach is the answer. Let us kill the wrong choices. Choice A, referral to a psychologist, treats a physical symptom as a character flaw and fails the child. Choice C, magnetic resonance imaging of the spine, is the imaging trap, unjustified when the spine and neurologic exam are explicitly normal. Choice D, a rectal suction biopsy, tests for the condition where nerve cells are missing from the bowel wall, but that shows up in newborns who fail to pass stool in the first days of life, not in a child toilet trained at age 3. The correct answer is choice B. Now let us handle belly pain, because step 3 almost always sends you down one of 2 roads, and age is the fork. Road 1 is telescoping bowel, where one segment of intestine slides inside the next. Look for a child between 6 months and 3 years with sudden bouts of crying where he draws his knees to his chest, and then critically, calm normal periods in between. Add a sausage-shaped mass on the right, current jelly stool, and often a recent viral illness. Your test is an ultrasound. Your treatment is an air or contrast enema, which is elegant because it both confirms the diagnosis and fixes the problem. Surgery is only for the child in whom the enema fails, or whose bowel has burst. Road 2 is appendicitis. Look for an older child or adolescent whose pain began around the navel and migrated to the right lower belly. That migration is the classic phrase. It is followed by loss of appetite, nausea, and low-grade fever, and on exam you find guarding and rebound tenderness. In children, ultrasound comes first because it spares radiation, and computed tomography is reserved for when the ultrasound does not answer the question. The treatment is removal of the appendix. There is never a version where you send the child home to follow up next week. The age and the pattern of the pain tell you which road you are on within the first 2 sentences. That wraps up our review of pediatric stomach and intestinal problems. Let us lock in the core ideas. Anchor on age and the hydration exam before you read a single answer choice. For the dehydrated child who is alert and drinking, fluids by mouth almost always beat the vein. For soiling in a toilet-trained child, clear the retained stool, then maintain, and never call it a behavior problem. For belly pain, let age pick your road, telescoping bowel in the toddler and appendicitis in the older child, and confirm with ultrasound before you operate. And for the vomiting infant, ask whether he is growing, because growth sorts the happy spitter from the child who needs a workup. To make this permanent, drill these stems in your question bank under timed conditions and read every explanation, even on questions you got right. Visit roadmaptoresidency.com for tutors and advisors who can build you a personalized study plan. If this video helped, please like and subscribe. Good luck on your exam, and we will see you in the next video.